Good afternoon, and thank you all for being here. As we close this conference, we're shifting from something powerful, momentum, to something even more critical, systems change. This shift does not happen in isolation. It happens at the intersection of policy, research, and living experience. For me, this is just not professional. It's personal, and it's lived every day. In my work, I traveled a journey alongside individuals, families, and professionals across systems of healthcare, education, and the justice system. What I see consistently is that we often have good intentions and we increasingly have strong research, but systems are still not designed to fully recognize FASD as a brain-based, whole-body diagnosis. Policy matters because it shapes three things: what gets recognized, what gets funded, and ultimately what becomes accessible. Without policy, even the best practices remain out of reach for many. As a support person to a young adult with FASD, I experienced the barriers to appropriate systems of care. Before diagnosis, there were more questions than answers. After diagnosis, there was clarity, but systems of care often were inaccessible. And what I've learned is that research can explain the why behind the behaviors. Policy determines whether supports exist. And living experience shows us what actually works in real life. Without all three working together, families are often led to build systems on their own. And as someone who also received my own FASD diagnosis later in life, this lens continues to evolve. Living experience brings something essential. It grounds this work in human impact. It reminds us that behind every policy conversation, every data point, every research paper, there are individuals navigating systems that were not designed with their brains in mind. So let's bring it all together. Policy, research, living experience are not separate lanes. They are interdependent. Research informs policy. Policy enables practice. Living experience ensures it is meaningful and effective. And when one is missing, systems fall short. So as we look across the United States, Australia, Canada, and the many other incredible countries that are joining us at this conference, the question becomes, how do we move from progress and pieces to systems that actually work consistently, equitably, and across sectors? And just as important, how do we learn from one another so we are not rebuilding from the ground up in every country, but instead building forward together? So my hope for this conversation is that we stay grounded in one core question. What does this look like for a real person tomorrow? Because that is where policy becomes practice and where systems change become real. Thank you, and I'm honored to guide this conversation.
All right, we're going to turn it over to our speakers. Thank you for being here.
Good afternoon. On December 2nd, 2025, the finish line years in the making was finally crossed. With the stroke of a pen, the FASD Respect Act became law. I remember the exact moment I found out. A text flashed on my phone from Senator Murkowski's office. I stared at the words, barely daring to believe them. Then she confirmed it. It is a done deal, and it is a very big deal. And I called Jen and told her, and all of a sudden, I thought she had had a heart attack. To every advocate, every family, and every leader in this room, look at what you have done. This victory isn't just a policy win, it is your win. Thank you from the bottom of my heart. So sitting along Jen and Chris, partners in crime, it is our honor to represent the United States in this closing keynote. And a footnote. Today, we aren't just looking back at the how, we're unveiling the roadmap for what's next. The era of sitting on the sidelines is over. The era of action has begun. But first, let's have a reality check. And all of us know this, that despite the prevalence, people with FASD remain unseen by the systems of care. And that message went clear and simple to members of Congress and their staff. The systems that could help that. They heard that over and over and over again. Unfortunately, in the United States, the federal funding to address these challenges has declined over the years. However, the field has been blessed to have had researchers at NIAAA, and we have seen that over the last several days, to continue to build our evidence base, deepening our understanding of prenatal alcohol exposure, neurodevelopmental outcomes, and effective interventions. And at the same time, the CDC has sustained critical work in surveillance, prevalence studies, and public health research on FASD. This continuity was critical because when we began the movement on the RESPECT Act, the science was there, the evidence was there, and the case for action was undeniable. But we all know the gap of services and the absence of an FASD-informed system of care for families and those living with FASD. And this is the gap we wanted to change. We need to look back at where we came because I love history and Michael did a fabulous job bringing us to the 90s. FASD advocacy did not happen overnight. It has been decades in the making. My own journey began in 1997, shaped by my work as a juvenile court justice and as Minnesota's First Lady. Around that time, the Congress received a landmark report from the Institute of Medicine, which made clear that alcohol causes more harm than any other drug combined. That report helped drive the FAS Prevention and Control Act of 1998, which funded federal efforts, including the FASD Center of Excellence. And the center gave hope to the FASD field and advocates for families. There was real progress during those years, and I was honored to be a part of that. And I know there are a lot of folks in the room that were part of that effort. And it brought the field together from every state, every year, to discuss all the work and progress that was being made. But the FASD program's authorization expired in 2007, and then slowly, SAMHSA started whittling away the center funding and eliminated it all in 2016. This was despite repeated efforts to reauthorize the legislation by members of Congress, which were introduced but no action taken. It was cut out of ignorance and not because of the work that was being done. But fortunately, as I've said, NIAAA continued to fund research, and in 2018, a major study published in the Journal of the American Medical Association gave us the now widely cited figure of 1 in 20 Americans affected by FASD. That evidence made the need for action undeniable. And I thought at that time that would give the FASD community something that we could go to Congress. And so when I joined the NOFAS FASD United Board now in 2018 to help advance reauthorization, One huge challenge was immediately clear. There was limited awareness of FASD on Capitol Hill. On our visits, staffers kept saying that it was a rare, single disease disorder and really did not understand the depth of the problem in their communities. This was going to be a monumental task to get anything done on FASD, unless we had a rich or famous champion. We thought maybe that's what was needed. Then came COVID. Well, while it brought us hardship, it also created an unexpected opportunity. For the first time, we were able to connect with policymakers and their staff through virtual platforms. That access helped us rethink our entire approach, how we communicated, how we organized, and how we built relationships. And it was in 2021 everything began to change. Tom had the foresight to initiate the FASD United Policy Center. We began our monthly policy webinars. And he also had the wisdom to hire this person, Jen the Wiz Wisdall, came on board. With the 117th Congress, we began working with the staff from our champions, Senator Murkowski and Klobuchar, and Representatives Betty McCollum and Don Young, to get together, to get another reauthorization bill introduced. And Jen, we would get together and she would say, Susan, what are you trying to do here? And she pointed out the name of the bill, and it was called the Advanced, I can't even remember the name, but she says, could we switch the letters? And if you do that, it will spell the respect. And in Congress, they always have what they call popular names for the bills. And so this became the name of the bill, the FASD Respect Act. And I can't thank this person more enough, because that was what was sold into the FASD community at large. So thousands of Zoom calls later, I don't know how many meetings we had, we began that journey. Decades of persistence became something more. Recognition, dignity, and hope for the FASD community, for millions of individuals and families who had waited far too long to be seen and heard. And in Congress, you never can predict what's going to happen. And we certainly didn't do that. It was a real roller coaster during all those years, but we rolled with it. And that's what we learned. And to get a bipartisan bill through the Congress is phenomenal. We ought to be very, very proud. Jen.
Raise your hand if you sat in on one of those thousands and thousands and literally thousands of Zoom calls. Thank you. You changed the landscape. We get to sit up here and talk about it, but you're the ones that did it. And we get asked a lot, what finally worked? What made this happen? Well, we also get asked about funding, but we'll talk about that later. But what moved Congress after 20 years? And in talking together, what we discovered really is it was a braid. It was something as simple as a braid. And they work connectedly, all of our strategies. And if you pull on one piece of the braid, the other ones fall apart. So the strategy that we used really integrated three very important things. The first was we changed the story we were telling. We made a deliberate decision to stop doing the same things and expecting different results. Legendary, I know, right? And one of the biggest things we changed is how we framed things. We left out the tragedy narrative. My children are not a cautionary tale. People hear me say this. We left that out. We left out the blame framing, and we moved away from the simple message of don't drink while pregnant, not because it's not important, because that allows people who are listening to our messaging on the Hill to say, oh, yeah, that's easy. It's preventable, don't worry about it. And that leaves out all the people living with FASD. So in came dignity, capability, and the language of neurodevelopmental disability. And most importantly, we brought in that language of hope, that we could do something together as a community. We could come together and do something. Because isn't that what we all want? Hope for a better future and life for people with FASD. We started asking a different question, not just what's hard, but what does success look like? What would it look like in a world where people had what they needed? What do people with FASD and their families actually need? We framed FASD as a public health opportunity, not a moral failure or a moral hardship. And we made the case that a brain-based disability affecting 1 in 20 Americans, backed by decades of research from NIAAA, CFASD, and the CDC, deserved a federal response centered in support. And that framing shift opened doors and political doors that the old framing had kept firmly shut. When you talk about FASD as a lifelong disability, you can build alliances with disability rights organizations, criminal justice reform, child welfare, rural health care. When your primary message is a pregnancy warning campaign, that's important, absolutely, but you can't build as many alliances. You're in a different room. We still talked about prevention. Of course we did. It's important. But we told the story, again, from the understanding that FASD is not as simple as it's 100% preventable. It's an and conversation. There's so much going on. And we also know that because FASD can occur with alcohol use before someone knows they're pregnant, that was mind-blowing to some of the folks we talked to. They thought it was a conscious choice. It's not a choice. So we had those hard conversations. And that's kind of the marketing piece, right? And I know the marketing can sound cold when you're talking about people's lives, but what it really means is we followed the science and believed in positive public health messaging, and we sold an ideal of support and services for a population that had gone unserved and unseen for way too long. So that was strand number 1. Number 2, we showed up. Every day, every week, every month, every year. We did not let it go. Not just when a bill was about to move, not just when we had a Hill Day, all the time. We had policy forums to educate people on what to say to their legislators. We went on Facebook groups and trolled Facebook groups to find how many of you did I meet through a Facebook group when I reeled you in, right? How many of our advocates did we do that? I'm looking at you, Annette Kunzman. We went to where the people were and got them involved and engaged and taught them that they could be a part of something bigger and gave them the tools to be a part of something bigger. We also got, and this is a really important piece, we got researchers involved. I want to give a shout out to Sierra Roser, and I want to give a shout out to Christy Petrinko. Because the way they integrated themselves with this movement and the way they stood alongside our advocates, talking about the science, but also advocating as people, because as a researcher, you can't lobby, right? We know this. The universities won't let you. That's just part of the job. But every single person in the United States has a legal right to talk to your legislators about things that are important to you. So if you're speaking for yourself, you have a legal right to do that. And I really appreciate the way that Christy and Sierra embraced that legal right. So by the time we got to Hill Day in September, just before the bill passed, it wasn't because of Hill Day. It was because of all this work in the background. It was showing up day after day, year after year, with the same message, with the same legislators, getting to know them and having them get to know us and the people in their community that have FASD. So the next strand was really that People with FASD and their families were not the human interest segment, they were the architects. What I mean by that, and I feel really strongly about this, we didn't post in our newsletter and hope that people found us, right? We actually went looking, we found them. And we had one-on-one conversations and group calls and everything to get them going. We talked to them about what was in it for them. We trained them and we kept training them. And so by the time we were having these calls with the legislators, our families, our self-advocates, they knew how to do it because they are the experts and they led the calls. They didn't wait for one of us. They were able to go in there themselves and do it. I remember Sean Patrick and Justin Shepard testifying in Congress at a congressional hearing, right? We were able to give that seat to them and frame them as the experts with backup testimony from our researchers, backup testimony from clinicians. They were the experts. The data tells the legislators why, and the stories of self-advocates and families tell them who. And when a self-advocate sits across from a legislator and says, "This is my life," it changes what the legislator hears when they read the bill text. It's not a small thing. That's the whole thing. It's 3 strands woven together continuously, and that's what worked.
Let's quickly talk about how this bill got passed, because we have plenty of countries with us, lots of state advocates, and we think that these lessons can apply to the work they're doing elsewhere and then implementing these programs in the states. 4 points got this bill passed. First, we had bipartisan leadership. This bill was carried by champions from both parties across multiple Congresses. And what we know now is that that kind of continuity isn't always normal and doesn't just happen. That happens because relationships were built and they were fostered, and they were maintained, not just when a bill was moving, but consistently across Congresses. Second, strategic positioning. We listened to our congressional champions and their staff, and we made the hard strategic decision to pare down the bill into its core, what was essential, what we knew would work, what we were told would be feasible, and what would be actionable. And we listened to their staff when they helped position the bill into a larger must-pass bill in the Support Reauthorization Act. These are insights that we wouldn't have known on our own, and we were able to rely on our congressional champions. That's what created the path forward. This didn't pass as a standalone bill, but it passed because it was placed where Congress would see it and where we knew Congress was going to act. Third, community mobilization, and that's all of you in here today. This is where the real momentum came from. Self-advocates, families, professionals, good neighbors, people all across the country who showed up consistently, not just at the end and not just when there was a call to action. We aimed to make this advocacy approachable. We gave people the tools and the language, the resources and support to engage. And over time, that turned into something real, something that our legislators could see and could feel and could hear. Fourth, we had sustainability and accountability baked right into the bill. And this matters a little more than it may seem at first. The law includes some funding authorization. It includes reporting requirements, and it includes a lifespan framework. That's what gave members of Congress the confidence that this wasn't just a symbolic newsletter bill, but that it was something that could be implemented in states with progress that could be measured. None of these elements could have worked in isolation. We know that bipartisan leadership created credibility. Strategic positioning created the opportunity. All of you, this community, created and maintained momentum. And the structure of the bill itself instilled confidence. That combination is what got the bill passed. And we hope that all of you in this room and those beyond this room will continue to fight to make sure that this is something built to last. So now that we've spent plenty of time talking about the how and the why, let's very quickly talk about the what of the bill. because again, we have so many countries, we have so many states here that can look at this as a model, and it's what the states are going to be looking to implement when they get home. At its core, the RESPECT Act is building a national framework to address FASD. But what is significant is how it's doing that. It's doing that by cutting across systems: health, education, social justice, child welfare, all of these systems that have always encountered FASD, but haven't always recognized it. This law isn't building something new from scratch because we know that's not something that was feasible. We know that's not something that would work. What it is doing is it's forcing these existing systems to recognize and to respond to FASD in a coordinated way. This is where the heart and intent of the bill comes in. It's placing a clear emphasis on building up state and tribal capacity to address FASD. Real change doesn't happen all at once, and it doesn't always happen at the federal level. It happens in states, it happens in communities, and it happens in the systems that all of you interact with every single day. The intent here is to give those systems the structure and support to start doing this work in a more meaningful, coordinated way. This can be done by improving screening and diagnosis, intervention and training, all of this paired with some technical assistance, again, to build that capacity and sustain that capacity over time. The new law also authorizes $12.5 million per year through 2030, and we need to be very clear about what that means. That number is a starting point, a springboard, not a finish line. It's establishing the federal commitment and creating the mechanism to do this work, but the work now is to make sure that that investment grows to match the need. The accountability component of the bill is also very important. The federal government is now required to report back to Congress in 4 years and every year after on the progress being made. But it's the sort of progress being made and measured that's important here. It's progress on awareness, identification, support for individuals and families, and prevention. But it's this last piece that really matters, because it's not just about prevention metrics now. We're placing support and prevention next to each other. It's about whether people with an FASD are actually being reached. There's one final piece that I'd like to share that really shapes the rest of the bill. The law now defines what it means to be FASD informed, grounded in evidence, culturally and linguistically responsive, and focused on improving quality of life. Quality of life. That is the shift made manifest. That phrase centers the people who are here. It sets clear expectations for how these programs are meant to be implemented. And it makes it clear that this is not just about prevention. It's about supports, it's about our systems, it's about real outcomes, and it's about people.
So let's talk about barriers. What nearly stopped us? And there were quite a few things, right? From a formula shortage to a couple wars to congressional shutdowns. There was a lot that happened in those years, but I think the bigger obstacles are the ones that we planned for. And the first obstacle was that our legislators really only knew about FAS and they only knew about prevention. And so we had to teach them that there was another way and there was more to it. It wasn't just this simple picture. It was an and conversation. Anybody here give FASD a seat at the table? That's the language we used. That's how we got around that obstacle. We made it clear that FASD had impacts in multiple sectors, not just one. The other barrier was that the community needed hope. After the loss of the Centers for Excellence, there were a lot of people that were really bummed. I was. We needed hope. We needed to see that change could happen, that we could make a difference, that things could get better. And they could get better for the people that we all truly, genuinely care about. That was braided in too. We used the language of hope. If this bill passes, it will make a better life for the people that we love. If supports and services are there, The people we love will have a better quality of life. That's important. So we braided that in. Positive but real messaging. So not the everything's terrible, it's horrible, and I don't know how to fix it, but yeah, this is hard, but if we had these resources, life would get better. Those kind of conversations mattered. Fragmentation made FASD genuinely hard to legislate. So the fact that FASD needs multiple seats at the table made it hard. And that's what we built into the legislation. A condition this pervasive across health, education, justice, and child welfare doesn't need to pick a lane. It needs a statutory mandate for cross-sector coordination. And that's what the FASD Respect Act does. And then there was congressional inertia, which was really, really real. And that's where showing up regularly, daily, persistently. I don't know how many of you got sick of the TikTok dance and do it along with me if you reached out to your 2 senators and your rep. Over and over and over and over and over and over again. There were weeks where we would have 20 to 30 meetings with legislators across the country. So when we got there on Hill Day, it wasn't a matter of us making a big deal on the Hill and showing up with our shirts. It was a matter of the legislators knowing we meant business because we showed up in force and they already knew what the issue was. So Susan, I will let you wrap it up. We've got 3 more minutes.
Oh, okay. Well, so where do we go from here? The work ahead. And I've been in this business for a long time, and systems work is hard. And we know, we've heard the barriers and we know they exist, but they're not impossible. And I think now we know what the possibilities are and the pathway forward with the Respect Act. But it's going to take a village. It's going to take all of us, exactly what we did in getting the bill passed. And this is a message that you can take in your countries. It can't be just a lobbyist and a few people and think you're going to get it done. And we've provided that pathway for states to begin to look at their systems strategically and where they begin. And that's, and so we started that process with our advocates in the United States. But Congress will be an essential partner with investment and leadership, tracking our progress and providing the funding. And I know we've talked about that all week long. Funding is policy, and it's not a dirty word. We're going to need funding. And I know that 12.5 million is not a lot of money, and we're asking more, but what you need to know is we can throw a lot of money at states, but they need money to begin to plan and come up with their strategic outlook on looking at those silos. There's a lot of funding that goes to states, federal funding that goes to states where FASD is not a part of the equation. And that's a wasted opportunity. And that's where states are going to have to look at the eligibility guidelines and those barriers. So that's all on the table. We had a 64-page bill when we started. The language that was passed was about 4 or 5 pages. There was a lot of good stuff on there that we left. And so that's going to we're going to be back in Congress looking at that, justice, education. So I want to encourage all of you in the United States to come along with us for the ride. We're going to need you. And I don't know that we need to, do we want to close it off? Okay. So I just want to thank all of you that have been part of this. And I want to leave the room and those in states and other countries, and it's a real one. What does your country or state need to reach its own inflection point, like we in the United States and in our states? And I think the answer begins with disciplined, hopeful, ongoing, consistent messaging. It requires persistence. And I think that's one lesson I've learned in life. And I learned it from my basketball coach. Persistence pays, and it will, and it paid for us. And persistence that doesn't fade. It demands that people with FASD are centered in every decision, grounded in, and it's got to be grounded in research. And I echo what Jen has said about research and professionals. You have to be part of this effort. We can't leave it on the shoulders of families and those living with FASD. And so the work is far from over, but I think what we now know, something we did not know before, it is possible. Thank you very much.
Thank you for sharing that inspiring story. We are going to move on to Canada and Australia. Doctors Reynolds and Elliott.
Wow, you all stayed. This is great. First, I want to offer my thanks to the organizers for the opportunity to share some of Canada's history with policy initiatives related to FASD. Now, I wasn't going to say this, but in a little bit of perspective, when I first started jotting down what I wanted to say on this topic, I quickly realized I had about a 45 to 60-minute lecture, but I've been given 5 minutes, which is actually probably a bit of a blessing because it will stop me from saying things about this topic that I probably should not say with an open microphone. Canada has interlocking federal, provincial, territorial, and Indigenous health and social service systems. And important legislative and policy initiatives have occurred at all of these levels. Indeed, most provinces and territories in Canada include FASD initiatives, either as specific programs or they provide FASD funding in the broader context of their health systems. These programs are highly variable in both scope and quality. So in the interest of time, I will focus exclusively on federal initiatives. So FASD has been recognized at the federal level as a national health concern in Canada since the early 1990s. Program authority and funding for FASD initiatives was first conferred on Health Canada and later the Public Health Agency of Canada in the 1999 federal budget as an expansion of the Canada Prenatal Nutrition Program. In 2003, Health Canada led a series of national consultations that informed the development of a document entitled Fetal Alcohol Spectrum Disorder, a Framework for Action. The 2003 framework was intended as a foundation for action at community, provincial, territorial, and federal levels, and includes several broad goals related to raising awareness and prevention of FASD, increasing diagnostic capacity and surveillance data, and increasing support, funding support for programs and research. In the years following its launch, the 2003 framework did indeed lead to several key milestones. Perhaps most importantly, the development and publication of the Canadian FASD Diagnostic Guidelines in 2005, which were updated in 2016. Now, since its release in 2003, the framework has undergone periodic review and evaluation of its impact. The most recent evaluation of the framework by the Public Health Agency of Canada in 2023 concluded that despite having ambitious objectives, FASD dedicated funding is limited and that important gaps to addressing FASD in Canada remain. 2023, the Public Health Agency of Canada also asked the Canadian Academy of Health Sciences to undertake an in-depth scientific assessment of FASD. Over an 18-month period, extensive public consultations were carried out across Canada. Scientific literature was reviewed to establish the current state of knowledge across all key sectors, and policy and legislation in multiple jurisdictions across Canada and internationally were summarized and compared. Guided by an independent expert panel, the final report, released in June 2025, provides a comprehensive examination of the impact of FASD on individuals and on society. In the words of the expert panel chair, it was abundantly clear how much commitment and work there has been across the country at the grassroots level, as well as regionally and nationally. And this effort has made Canada a recognized leader in the field in many ways, even if there remain important gaps, unmet needs, and substantial room for improvement. Now, a feature of most FASD strategies is the recognition of the critical importance of effective mechanisms to ensure coordination and collaboration amongst the many different sectors of government that need to work together. These should include explicit articulation of who will participate, the governance structure, and mechanisms for accountability. This, unfortunately, is where we have largely failed. The 2023 evaluation report cited above noted that in Canada, there is no national approach or strategy that defines the roles and responsibilities of all FASD key partners and stakeholders to help coordinate efforts. The 2025 report amplified this conclusion, noting the critical role of a clearly identified coordinating or backbone organization, and stating that the expectation that collaboration can occur without a supporting infrastructure is one of the most frequent reasons why it fails. In 2022, Senator Mohammed Ravalia introduced Bill S-253, an act respecting a national framework for FASD, into the Senate of Canada. Following the federal election in 2025, Senator Ravalia reintroduced the bill, now S-234, which is currently under review by the Standing Committee of Social Affairs, Science and Technology. Senator Ravalia, in presenting the bill to the Senate, stated that the purpose of this bill is threefold: to establish a national framework for FASD, to ensure consistent access to diagnosis, prevention, and support services across the provinces and territories, and to recognize FASD as a national health and social policy priority. Bill S-234 calls on the federal government to work with all key stakeholders to create national standards that would guide prevention, diagnosis, professional training, public awareness, and research coordination. Now, it should be stressed, just as you've heard here, that this bill would only establish the framework itself. Any decision about detailed funding structures would follow during implementation if and when the bill is enacted by Parliament. Thank you for your attention.
Thanks, and I'd like to start by paying my respects to the traditional owners of the lands on which we meet and on which I live and work. Australia got off to a late start in addressing fetal alcohol spectrum disorder, but has maintained a sprint for the last 25 years. And although we've made huge gains, the finish line remains well over the horizon. Leverage can be defined as a means of using power or persuasion to influence a person or a situation. In Australia, the achievements made in policy relating to FASD can be attributed to several key levers: the voice of lived experience, landmark research, personal relationships with politicians, a collaborative national approach, and the tenacity of women. I'm going to tell you a story now to illustrate this. The voice of living experience was the sole voice at the start line 40 years ago, when Sue and Tony Myers fostered an Aboriginal girl who was struggling at home and at school, but for whom they could find no answers and no help. Eventually, their daughter was diagnosed with fetal alcohol syndrome in Canada, and they embarked on an ongoing advocacy journey. In 1999, Sue founded the National Organisation for FASD Australia, and since 2012, it's received Australian government support for a website, a helpline, and caregiver peer support. It has established a parent and carers expert advisory group and a lived experience speakers bureau, and both have a key role in influencing government. In 2009, Aboriginal women June Oscar and Maureen Carter initiated the Lililwan Project, a landmark research study on FASD prevalence in the very remote Fitzroy Valley of Western Australia. To secure funding, the project leads, 2 Aboriginal and 2 non-Aboriginal women, visited Parliament House in Canberra and met with Jenny Macklin, the Minister for Indigenous Affairs, and Tanya Plibersek, the Minister for the Status of Women. Gaining direct access to ministers is notoriously difficult, but June had previously established a relationship with Tanya when advocating for alcohol restrictions in the Fitzroy Valley. On this occasion, a 60-minute meeting led to an immediate commitment of $2 million. Witness the power of trusted relationships with politicians and Aboriginal voices of lived experience. The Lililwan project identified very high rates of PAE and FASD, and it captured the imagination of the media and of policymakers. Tristan, a film made about life's challenges for a young boy with FASD, raised awareness of the issue in remote Australia and beyond. The film was launched in Sydney by the Governor-General, and it was screened at the United Nations Permanent Forum on Indigenous Issues in New York. This, in turn, piqued the curiosity of Member of Parliament Sharman Stone. She was previously the Shadow Minister for both early childhood education and women, and had published a documentary history on the attitudes affecting official policy and the Australian Aborigine. What an ally she proved to be. In May 2011, she introduced a bill calling on the Australian Parliament to support the prevention, diagnosis and management of FASD, and this was passed with bipartisan support. Just 6 months later, the government initiated a national inquiry into FASD, and they even travelled to remote Western Australia to hear firsthand the voices of local Aboriginal people. When the report was published in November of that year, the foreword read, "Amongst all the voices we heard, the most moving was that of Tristan, a young man affected by FASD. He'd said, 'I wish I can be a policeman just when I grow up, but I just want to be normal first. I just want to be normal.' The report concluded, 'We owe it to Tristan and to every child and every woman and every family in Australia to bring to light the risk of FASD. We cannot keep hidden the devastating harms being caused by prenatal alcohol exposure.' The inquiry recommendations received bipartisan government support, representing a turning point in FASD policy. Within a year, the Health Minister had launched an action plan to reduce the impact of FASD, accompanied by $10 million, and in 2018 launched the current 10-year National FASD Strategic Action Plan, which provides the framework for Australia's response. Collectively, these policies have led to a commitment of over $115 million with tangible benefits, including an advisory group to the Minister of Health, diagnostic guidelines and specialist assessment clinics, a national register, a national awareness campaign, mandated warning labels on alcohol, the FASD Hub and Learning with FASD websites for clinicians and educators, and inclusion of FASD in policy regulating the National Disability Insurance Scheme and Medicare billing. And we also have an annual day when lived experience researchers and clinicians visit Parliament House. So giving voice to lived experience to clinicians and researchers and taking a collaborative national approach to FASD has indeed shaped the policy landscape. However, there is more to be done, and we continue to advocate for legislation to reform taxation and pricing to prevent alcohol promotion and advertising, and to limit the influence that the alcohol industry has on public health policy. Thank you.
So we're going to hear now from different countries, beginning with Magdalena Borkowska, Poland.
Thank you. I would like to thank you for the opportunity to share the information about our progress in addressing FASD in Poland. Since 2007, Poland has launched a nationwide public awareness campaign and enacted 2 legislative bills related to FASD. In 2020, we developed and updated national diagnostic guidelines, which are freely available to professionals across the country. We have also established comprehensive care centers in 3 provinces, setting a standard to expanding services to all regions in Poland, the 13 left. Our ongoing mission is to empower professionals through training, increase public awareness through research, and promote prevention efforts. However, challenges remain, such as implementing a national care model and breaking down stigma, both of which are still works in progress. There is a renewed hope with the active involvement of Member of Parliament Ms. Monika Rosa, who is championing FASD across health, education, and social policy legislation. I invite you to read my article in the conference proceedings and consider sharing Poland's journey on the global stage. I hope also that we can continue our journey, sharing knowledge and supporting each other in the field of FASD during the EU FASD conference in coming September. Deeply, I believe that we can build a future of understanding and support for those affected by FASD. FASD matters. Thank you.
Thank you. Next, representing Mexico, Esteban Nolo Hernandez.
Hello. Well, in Mexico, policy-wise, the situation goes like this. On the one hand, there are some policy signals. The General Health Law partially recognizes the risk by framing alcohol use during pregnancy as harmful when excessive. We need to change that. There are some clinical guidelines that acknowledge the risk for pediatricians or OB-GYNs. There are warning labels that are also mandated on alcoholic beverages. However, these signals have not yet translated into real public health awareness or system readiness. There are no specific guidelines for FASD. There are no diagnostic clinics. And of course, there are no sufficient capacity for detection or care. So over the past year, we have focused on closing that gap with your help. Thank you very much. We held the first international conference of FASD in Mexico City last year. Thankfully, we have the support of FASD United. Thank you, Jennifer. Thank you, Susan. Thank you, Erin. It's been really, really valuable for us. We are engaging actively with health institutions and joined global networks. Now we are FASD United affiliates. We're very proud of that. Importantly, we also generated the first hospital-based data on screening for alcohol use during pregnancy in over 30 years. That's amazing. So while Mexico is not yet advancing to formal policy implementation, we are working very hard to build the system, the conditions that allow that to happen and to become real outcomes. So we're very excited. Thank you for your support, and that's it.
From South Africa, Liana Olivier.
Hello, everybody. The work in South Africa started in 1997 when our organization, the Foundation for Alcohol-Related Research, was founded. FAR is the leading NGO and also research organization in South Africa and service provider, and we're also rendering the only diagnostic services in South Africa. One of the things that are holding us back in South Africa is that we don't have a promulgated Liquor Act. Our draft Liquor Act has been hanging since since 1917 to be approved. Although there's national recognition that FAR is a problem, it's not the recognition, it's not actually recognizing that it's a public health problem. And I think all of you would agree with prevalence rates as high as 2 to 3 per 10 people in a community, we've got a public health problem. We do have focused policies. We do not have focused policies and intervention programs in the government departments. We've got general programs, like stated on the slide there, looking at health of mothers and children in the Department of Health, inclusive education system in the Department of Education, and then the National Drug Policy Act. FASD, and that was a breakthrough, is mentioned in all of these policies, but unfortunately, there's no focused service rendering as well. The prevention and management programs are mostly done by FAR and then a few other NGOs who are doing awareness and prevention work specifically. And here I need to acknowledge the role of the media, which was very important in South Africa to get on board to help us to raise awareness and to gain support for the fight against FASD. We're the only organization doing training in South Africa for professionals, undergraduate students, and also community members, and we've trained other NGOs to do the same. Nothing is being done from government side. And as we've said over and over again at this conference, funding is extremely, extremely important. Without that, we can't have diagnostics, services and care. And just to give you an indication, our organization is getting less than 0.2% of funding from government. I thank you. So we've got a lot of work still to do. I thank you.
Our final country representative will be Anya O'Halloran from Ireland.
Díomh, is Misha Anya O'Halloran as FASD Ireland. Hello, my name is Anya O'Halloran and I am the FASD Hub Coordinator at FASD Ireland. Ireland currently does not have a dedicated national strategy for fetal alcohol spectrum disorder, despite increasing recognition of its impact across government departments. While guidance exists through the Health Service Executive, public awareness of the risks of prenatal alcohol exposure remain limited and inconsistent. The HSE continues to reinforce blame, shame and stigma of FASD among women, with the latest campaign launched in April 2026 targeting women over the age of 35. There are no mandatory education programs in schools, and messaging to the general public is not current, sustained or targeted, i.e. peak conception times are St. Patrick's Day and between Christmas and New Year. Research, including work by the Royal College of Surgeons in Dublin, University of Galway and Trinity College Dublin, shows a clear unmet need, particularly in relation to diagnosis and support services, which vary significantly across the country. Compared to countries like Great Britain, Canada and Australia, Ireland lags behind in having a coordinated whole-of-government response. In summary, while awareness is beginning to grow, Ireland remains at a very early stage in policy development, with significant gaps in prevention, education and support that need urgent attention. Gur míle maith agaibh go léir. Thank you.
I want to thank all of the speakers for sharing this international perspective. You can read about other countries in the syllabus, including France. We have time for one question. Who will it be? So I don't think we have time for somebody to run to the microphone, but I have one and I'm going to ask a question, which is, and this is going to be to whoever wants to answer it. If you could wave a magic wand and have one legislatively plausible initiative, what would it be?
Dr. Turnus, show me the money. I would like, so this year, we put in for appropriations. We know the bill came in at 12.5 million, right? And that is not nearly enough. It's enough right now, but it's not going to be enough. And so we were told by our legislative champions that every year we need to put in for 10 million more in appropriations. So this year, that's exactly what we did. We put in appropriations requests for 10 million. We put in almost 4 times the number of appropriation requests that's ever been put in before for FASD appropriations increase. We need your help in meeting with your 2 senators and your 1 rep about that. And I would say we have a very good shot at getting that passed and getting more money added. And guess what? Next year, we're going back for more. So getting in that loop, that's what it would be.
Okay, I have
This genie only granted 1 wish, but I grant you a second wish.
I think we need to change eligibility standards to include those with FASD in education, developmental disabilities, to bring equity.
Thank you. We're going to conclude by acknowledging the people in this audience and the people on stage who work so hard together to advance this field. I want to particularly acknowledge FASD United for their efforts in this success. And also for their support of this conference, which brings us all here together to be able to share knowledge and inspire each other to do more. Thank you.